Thank you for the opportunity to be able to introduce our speaker for today, Dr. Madeleine Duvic. Dr. Duvic is one of the celebrities in dermatology. Duvic is a household name among dermatologists worldwide for all of her accomplishments, especially in the area of cutaneous T-cell lymphoma. We have very few celebrities, and she is one of them. Everyone knows that she has the largest mycosis fungoides clinical program perhaps in the world. She has a research laboratory which is second to none. I don't think there's much that's been new and innovative in cutaneous lymphoma that hasn't originated in her laboratory. Most of our mainstay therapies that we do every day, Bixaritine and a lot of others, originated in her laboratory in Houston at MD Anderson. Today she will present various cutaneous T-cell lymphomas, and we're really lucky to have her here today. She's a professor of internal medicine and dermatology at University of Texas, MD Anderson. And Madeleine, it is a pleasure to have you today. Thank you.
It's really an honor and a pleasure to be here today. I love Washington, and I'm enjoying learning about your programs here. And I was asked to do a translational talk, so I've tried to make it translational rather than just pictures of patients. There's some patients in here too, but the earliest description of MF was made by dermatologists. Albert described follicular trophic MF here on the bottom there, and Albert Sezary figured out that some red people had weird-looking Sezary cells, the cerebriform cells. He called them cellules monstrueuses, monster cells in the blood. And we now know that a lot more about T cells in that they mature. They have to come from the bone marrow, and then they enter the thymus, and they kill off all the T cells that recognize self-antigens, and then they kind of split. Some become part of the innate immune system, and some became part of the adaptive immune system. And then they can acquire CD4, CD8. Cells can have both, either or none, combinations of these. They can differentiate into effector T cells, which are the MF cells, or the memory cells, which are the circulating Sezary cells described by Sezary. And based on their pathway of differentiation, they can, and then transformation, they can become hepatosplenic cancers or paniculitic gamma delta, which are very aggressive, as opposed to the non-gamma delta lupus-like paniculitis. The NKT cells can give you the central midline lethal granuloma type of lymphoma, or you can get EBV-associated NKT cells. And then the follicular helper cells become angioimmunoblastic T-cell lymphomas. And then MF can, and Sezary can either be memory or effector cells if they stay in the skin versus the blood. And then if they have a CD8 predominant marker, you can get CD8 lymphomas, which can be aggressive or non-aggressive. And then what's ever left over gets put into this waistband of peripheral T cell not otherwise specified. So there's been a lot of work done here to understand this, and it has resulted in a classification system called the WHO-ERT system. And there are about 20 MF variants that have been reported. The most common are follicular trophic MF and You can get granulomatous slack skin syndrome, which looks a lot like your PXE patients that we just saw. And then the next group of lymphomas are the primary cutaneous CD30 positive lymphoproliferative orders, and this includes primary cutaneous ALCL, lymphomatoid papulosis. Another classification is the subcutaneous paniculitic like T-cell lymphomas, and then the more aggressives are the Sezary and the NKT nasal type, and then the NOS peripheral T cells that can have weird rashes. So these are the cubby holes that we've created for these tumors, but I get sent a lot of people who don't fit these or who are combinations of one versus the other. So when we think about disease, it's a thing that we create in our mind to shove patients into sometimes, unless, of course, it's like simple genetic one gene. These inflammatory diseases don't always fit into their boxes. So the epidemiology of mycosis fungoides is the most common CTCL. It occurs at 3 to 8 million or 6.4 million in the US. The annual incidence has increased by almost threefold in the last decade. The incidence in men exceeds that of women, and blacks have a lot more CTCL than whites, 9 versus 6 per million. There are about 1,500 to 2,000 new cases in the US per year with a prevalence of 20,000. And we've recently reported hotspots in Houston, Texas. After seeing patients for 30 years, it started looking like there were areas that had more incidence of CTCL than others. And Dr. Larissa in Pittsburgh found the same thing. And these studies have been extended to Canada, where industrial areas are more likely to have CTCL. So the epidemiology gives you hints on causality, and these are studies that really need to get funded and carried on. And maybe you all in Washington will look and see what the incidence here is. So MF and Sezary are diseases of the T-cell receptor. And all of the patients that we studied in a translational study had mutations of the T-cell receptor pathways as part of their problem. And usually T-cells get educated by class 2 macrophages or dendritic cells, Langerhans cells. But it's also possible to have a viral or a bacterial superantigen that bypasses HLA and stimulates the T cells. When there is an antigen presented to T cells, the usual thing is a polyclonal expansion of the T cell receptor cells. But if all of the cells are stimulated and there's a mutation one that gives it an advantage, then you can get what looks like a monoclonal expansion of T cells. And we use that clonality to help us diagnose a lymphoma. So I've always thought it was interesting that CTCL patients have HLA associations, just like autoimmune diseases are associated with HLA. And HLA determines what antigens bind to the Langerhans cell to be presented to the T cell. So some of the class 2 antigens are increased in Sezary, DR5, and this is a common, and also DQ beta 03, which goes with DR5. This is an HLA type that you see with alopecia areata and melanoma, scleroderma, and vitiligo. A lot of autoimmune diseases share this particular HLA type, and this is work that we did years and years ago. And the overall risk is 7.75 of DQ beta 502 with Sezary syndrome, and that's a pretty high risk factor. And we've reported patients who have had MF in association with the most common blood pressure medicine, hydrochlorothiazide. And if you catch patients early in this process, you can cure their MF by just withdrawing the drug. the SSIs, Prozac, and the other serotonin uptake inhibitors. We've reported a couple of cases of infliximab-induced CTCL, anticonvulsants like Tegretol or Dilantin, and then chemicals, especially in the petrochemical, benzenes, rocket fuel, flame retardant clothing, and infections. And this is what I think is really interesting, is what really causes MF. Is it a response to an antigen? It's not going to be probably one antigen. It'll probably be patients with a genetic predisposition who get exposed to an antigen that can initiate the process of creating a polyclonal clone that then has an advantage of growth and has lost apoptosis. So I'll show you some evidence for this. So so staging is done by the T&M stage, and we usually divide early patients from the advanced patients here between 2A and 2B, 2B being tumor. And most of the staging is driven by the T, or the skin stage. And this is what the skin stage looks like: a patch, mini patches, a tumor, and erythroderma. And this is what the biopsy should look like. There should be epidermatrophism. There should be T cells into the epidermis. That's the most important feature for diagnosing MF. And then there should be CD4 exceeds CD8. But there are patients who have CD4 negative, CD8 negative MF. And then there are patients who have MF who may have too much CD8, like the juvenile MF patients. And most of the patients staying with the pan-T marker CD3, and CD4 and CD3 look about the same in early MF, same intensity. So here's a patient who usually doesn't come in, but maybe on your complete exam you notice one single patch of redness, and this is where it starts. And it's interesting, if you ask patients' history, they can sometimes tell you the date that they got their first patch. And if you can catch it at this stage, you can probably cure the disease, because it's like a Harrow patch, and then it disseminates like PR later in many patients. And this is a culprit for not diagnosing MF. All the steroid creams that the patient puts on when they see their meeting of 6 dermatologists prior to biopsy, they've put on these steroid creams, and what that does is it takes the T cells out of the epidermis, and you lose the epidermal feature that's required for diagnosing MF. So without treatment, this lady goes on to have generalized patch stage MF. This would be T2A, because there are no plaques here. And this is when we usually see the patient, and they've usually seen a bunch of dermatologists. So when you have a patient with MF, you need to work them up and stage them. And your staging depends on the stage that you think they are. Like if they just have 1 or 2 lesions, the workup is minimal. If they are extremely red and erythrodermic, then we need to do things like staph cultures and bone marrow and flow cytometry of the blood. And our institution does a lot of immunohistochemistry to work up the biopsies. It's also, we do clonality by the old-fashioned way of PCR, but there are better ways now. And we don't do Sezary counts, we do flow cytometry and look for the 4 positive 26 negatives or the 4 positive 7 negatives. We don't do a bone marrow unless there's blood involvement, or the patient has some sort of signal that there's something wrong, like low platelets. And we usually do HIV and hepatitis screen if the patient has had blood transfusions or lived in risk areas. LDH is a good marker to follow for progression from skin to node, or more serious advanced MF patients usually have a LDH, and it's a prognostic marker. Many patients with MF have low magnesium, and I don't know why that is. It's kind of a mystery, but I check that, and liver function test. And then we wrote a paper about low vitamin D, which everybody has, but in kids with MF, it's like 7 or 8. It's like the Ricketts range of vitamin D, and vitamin D is also, as you know, is important in the body. Is needed for calcium metabolism and bone health, but vitamin D can be supplemented, and so I usually check it. So there are new staging tools for MF, like flow cytometry, should be used to define the blood, and it can be quantitated. T-cell gene rearrangements can be detected by PCR, and there's spectrotyping, and then there's also sequencing the T-cell receptor, which is going to be state-of-the-art. And the sequencing now is down to about $500 per patient, which makes it somewhat, it may be available for everyone in the future. And then CT scans are usually what they use for other lymphomas, but actually a PET CT scan gives you more information, especially if there's subcutaneous disease. So this is important because to diagnose early MF, you can use the ISCL 4-point algorithm that was published in a consensus trial in the JAD, and you need two clinical features such as persistent dermatitis, sun-shielded areas, heterogeneous lesions, and then poikiloderma. But it misses the older people who just present with itchy, dry skin, no lesions sometimes. The pathology needs atypical lymphocytes. The nucleus has to be abnormal. There must be epidermatrophism, and they want minimal spongiosis, although I've seen lots of MF patients who have spongiosis. I don't think it's that important. The immunohistochemistry we mentioned, loss of CD2, 5, and 7 is also frequent. T-cell clones are not diagnostic, but they can be prognostic. And we found that if we had the same clone over time and space, here's the PCR product, then it raises your chances of progressing. This is a polyclonal pattern. And these are some of the markers that can be used as targets. CD3 is, there's a diphtheria toxin to CD3. There was a monoclonal antibody, zolanulimab, that bound to CD4. And there's CD5 there's a phase 1 trial of CD5 as the target for activated T-cell marker by CAR-T therapy. And then there's CD30, and this is activated on both T and B cells and is the target of the antibody conjugate called brentuximab vedotin. And I'll spend some time talking about these new targeted therapies today. So because we have such a large clinic, and because I'm bored on the weekends, we did a long-term outcome study of our patients beginning in the 80s, from 82 to 2009. And we looked at Kaplan-Meier and Cox hazards, and looked at uni and multivariate factors. And we were interested in whether there was a difference between plaque MF and patch MF with disease-free survival and overall survival. And interestingly, these are people with patches, and they can have either localized patches of less than 10%, or they can have more than 10%. And they have pretty much the same overall survival curve. But when you start getting plaques, even if they're limited 1B patients, and especially if they're 2B, which are plaques greater than 10% of the body, and you can have the patches with the plaques, of course, there's a big difference in the overall survival of these people who just have plaques and look like psoriasis patients. Then they're almost the same as the tumor patients. And then the patients with erythroderma usually mostly have Sezary syndrome, and they have the worst prognosis. But think that we've increased their lifespan from 2.5 to 5.7 years by our immunotherapy. So this is a good example of a patient with Sezary syndrome. It's defined as a patient must have 80% of erythroderma to be considered erythrodermic in a T4 patient. I have found that erythroderma is associated with staph colonization, just like in atopics when they turn red or have a flare, you can often find staph on them. So I engage in vigorous anti-staph campaigns that include bleach bath and Batraban and Hibiclins and acetic acid rinses and anything I can, and antibiotics of course, and anything I can do to keep the patient staph free. And I have found that doing an antibiotic for 10-day courses leads to getting them resistant, and it's better to leave the patients on long-standing dicloxacillin or doxycycline than it is to start and stop when you're trying to decolonize them. Sezary patients may also have adenopathy. It's usually reactive or dermatopathic. They get ectropion from the pull of the skin on the eyelids. They get keratoderma, and we did a study just with the medical students in teaching them how to do KOH exams. I made them scrape every Sezary patient's keratoderma, and 60% had athlete's fungus associated with the keratoderma, and that's a treatable entity. So I acknowledge the medical students' help in this trial. So the reason Sezary patients don't get diagnosed, and Frank and I were talking about this last night, is because the Sezary cells have lost the epidermatrophism, and they're down here around in the dermis around the blood vessels where, I don't know, the pathologist isn't looking for them or something. So the erythrodermic patients have their cells down here, unless they evolved from mycosis fungoides originally and had epidermatrophism first and then they develop Sezary. Then you'll find the cells. And the markers that we routinely stain for are CD25 because we have a phase 2 ONTAC study, and ONTAC binds to the T cell receptor as stained by CD25, and we use brentuximab vedotin for the ALCL group of patients. So it's important to either look at the blood smear or get flow cytometry on anybody who's erythrodermic or almost erythrodermic, so that you don't miss the Sezary patients. So this is what flow looks like. Normal flow, this is CD4 against CD7 and CD26, which are the two Sezary markers. And when you have normal patients, they smudge out in this line, but if you get a little circle here, these are the malignant cells, and are negative for CD27 or for CD7. So looking at looking at the blood involvement of all of our patients, if you had B0, which was less than 1,000 cells, your overall survival, if you're erythrodermic and present, is 7.6 years. If you're B2, which is 1,000 to 10,000, your overall survival is 5.4 years in our patients. And what really mattered was B3, which is greater than 10,000 cells. This is the formerly published overall survival for any Sezary patient, 2.4, but it's really for the more patients with the highest T cell numbers, Sezary cell numbers. And so blood is a major factor. Blood having B2, or B3 really makes a difference in overall survival. So this just reiterates most of what I said. There's dysregulation of cellular and humoral immunity in the Sezary patients. As the disease progresses, there's decreased cytotoxic T populations. Those are the CD8 cells and the NK cells. And there's an increase in the T regulatory cells. These are the T cells that shut down the immune response. And as the patients worsen, they can get herpes infections, they can get Kaposi's varicella-form eruption, they can get increasing severity of bacterial infections, especially if they have ports or lines. They can get septic really easily. And what's ironic is that they don't get fever when they get sick or septic. They get low temperatures, and so they may not go to the doctor with a low a low temperature. And then we mentioned the disease-specific 5-year survival is less than 25%, overall survival of 2.5 years if there's B3. And so most of the therapies for Sezary in the past have been palliative, but that's about maybe to change, hopefully. So the malignant T cells that have been launched, they express the CD4, which is part of the T cell receptor, CCR4, which is a molecule that lets T cells into the skin through binding to TARC, and CLA, and they make a lot of cytokines. So they make Th2 cytokines, IL-4, which causes increased IgE, and decreases the T1 gamma interferon type of cytokines. IL-5 causes eosinophilia. IL-31, which is a major cytokine, produces the pruritus. And so there's an antibody to 31 that's going to be tested and will be helpful in hopefully controlling the major symptom of patients with MF and advanced MF and Sezary syndrome, which is pruritus. And then these cytokines like IL-10 and IL-5 decrease cellular immunity and decrease dendritic cell function. So this is how I treat erythrodermic patients with CTCL. I've already mentioned the staph decolonization, but moisturizers are important, and topical triamcinolone is better to use than systemic. Once a Sezary patient sees systemic prednisone, it's hard to get them off, and they become steroid addicted. And so a lot of patients I get sent because they've been steroid addicted, so I try not to do that. And I use Dr. Rook's combination immunotherapy, which includes photopheresis, bexarotene or interferon, and/or I've been using a lot of gamma interferon these days because it seems to overcome the Th2 phenotype that the Sezary patients get. And GM-CSF is also good for beefing up your macrophages. And the second line of therapies, if this immunotherapy fails, which it doesn't fail, it usually helps about 90% of the patients who get on it, but there's second line agents such as the HDAC inhibitor romidepsin, which decreases Sezary cells, and vorinostat. And then there are the targeted therapies that are listed here, which we'll talk about a little bit more. And then we've been, in our young Sezary patients, we have been doing allogeneic stem cell transplants, which we do total body skin electron beam followed by non-ablative allos. And we've been able to cure some of the Sezary patients with this approach. So we have been interested in why does photopheresis work, and why does it work in MF and Sezary, and also in graft versus host, because they're two polar opposites of the immune response. So this was sort of thrust upon us by our first patient with invisible Sezary syndrome and MF. He went to the doctor to get some moles and seborrheic keratoses cut off of him, and they were full of lymphoma, T-cell lymphoma cells, but he had no evidence of mycosis fungoides or Sezary on his skin. He wasn't red or didn't itch, but his peripheral blood flow cytometry showed 17,000 Sezary cells in his blood without any skin manifestations. And so we typed his cells and found that they were T regulatory cells. And this is what happens in CTCL. There's cytokine modulation from Th1 to Th2, and that involves the participation of the monocytoid dendritic cells that make gamma interferon and and induce CD8 cytotoxic cells. And that's what happens when you're turning on graft versus, that's the anti-tumor effect in CTCL. In plasmacytoid dendritic cells lead to suppression, and that's what you need for graft versus host disease or autoimmune responses. So we started looking at monocyte function in patients with T-cell lymphoma, Sezary syndrome, and we found that the monocytoid dendritic cells were increased in graft versus host and Sezary cells, and the plasmacytoid dendritic cells go up with GVHD and down with Sezary syndrome. So it's all mediated by the macrophages. And the ratios of dendritic to plasmacytoid dendritic cells reverse with, in the opposite direction when you look at GVHD versus Sezary syndrome after ECP treatment. And most of the patients who get well with photopheresis actually have T regulatory cells as their tumor cells. And T regulatory cells express this molecule called FOXP3. These are the different markers on the T cell that are now being targeted for therapy, like CD25 in ONTAX, CD4 in Zanolimumab, CCR4 in for Mogalizumab, and these are the activated T cell markers. The checkpoint inhibitors, PD ligand and PD ligand inhibitor, are new targets for therapy. And so MF starts as an early disease. The cells become resistant to apoptosis, and there are genomic and epigenetic changes as well. That's why the HDAC inhibitors work in this disease. And there's accumulation of different molecular abnormalities, such as defects in the T cell and cytokine signaling pathways. And there's constitutive activation of the STATs and NF-kappa B and AP1. So it's my feeling that in order to cure Sezary or make a big difference, we need to be combining pathway inhibitors of all of these three pathways instead of just picking a single molecule and developing that. We need to get some combination trials going. And then in the advanced stages of the disease, we can get large cell transformation, which is just bigger cells, and it's associated with poorer prognosis if it occurs early in the course. And you get genetic instability, and I'll show you some of the work we did in this area. So this just shows the Langerhans cells that present antigen to the T cells. These are the keratinocytes, which also participate in the program. And these cells get into the blood through markers like E-selectin. And these are just the cytokines that are produced by the CTCL cells and the infiltrating CD8 positive tumor cells. Now these CD8 cells can keep MF in check until they're lost. And these are just all the list of the cycles and the genes that have been found to participate in CTCL. Again, T-cell signaling genes are most important. And we looked at Sezary lines and patients' blood samples and found that the earliest change that we could see was the loss of FAS. Here, you can see it's gone. Here's the control. And FAS and FAS ligand induce cell death. So when a cell that has FAS ligand on it meets a cell that has FAS, they kill each other. And that's what's happening with the CD8 cells here are undergoing apoptosis in response to FAS and FAS ligand engagement. And so this is a listing of all the changes. the steps to becoming a Sezary patient. You have chronic antigen stimulation through the T cell receptor. It causes IL-2 to be produced and generating TH2 cytokines, as well as effector and central memory cells. We've mentioned fast ligand, but the JAK-STAT pathway in NF-kappa B is equally important. There's chromosomal instability. There are DNA repair mutations. There's 50% have loss of P53, especially patients with large cell transformation. And there are mutations also seen in P16 and P14, especially in large cell tumor patients. There's a growth advantage that's by overexpression of c-MYC, and there's engagement of the AKT pathway, so there are gamma delta inhibitors of AKT that are being developed right now in phase 2 trials. And then there's the RAS-ERK pathway that's important in melanomas, also important in CTCL. And another interesting new area for CTCL is the microRNA regulation. There's overexpression of microRNA 155 in MF lesions, but not in Sezary. And there's a target, an oligo inhibitor for this that's in clinical trials right now. And then loss of adhesion molecules like CCR4 can drive the disease to progress. And you can progress by having cells go from up in the blood. You can get large cell transformation. You can get large cell transformation in early stages as well. About 16% of early stage MF patients will have large cell transformation. And then you can get a tumor. Those are some of the ways you progress. So we studied 37 Sezary patients, and we compared DNA extracted from their purified T cells, malignant T cells, to fibroblast DNA as a normal control. And this is each one of these boxes is a patient going down. And this is the mutation rate of the patients. And some of the patients had very low mutation rates, like these two, and some had very high mutation rates. And the mutation rate in CTCL is about the same as it is in melanoma and skin cancers. And you can see that each patient, these are the patients who are P53 mutants. These are the patients with CCR4 mutants. Another frequent one is CARD11, which is part of the T cell pathway. Very few patients FAS, only 4 patients had mutations in FAS. There were a lot of patients in ARID-A1, and ZEB is another common one that's involved in T cell signaling. It inhibits T cell signaling, so it's lost. And anyway, there are less as we go down the list, but you can see that each Sezary patient has a unique set of driver mutations there. So that's going to make it challenging for us to cure CTCL if each patient has a private group of mutations that is their problem, and if they can escape by getting more mutations. So this is kind of the flow. The stats maybe go first, and dysregulation in IL-2 signaling, followed by anti-apoptosis and NF-kappa B engagement and AP1. So this is just the frequency of the mutations that we found, and some of them were associated with deletions, like P53 deletes on P17. This is an important marker for CLL patients as well. And then the CCR4 is a gain of function. So I'll show you some of the work here. So this represents the whole genome, and this represents things that are increased and decreased. And so you can see c-MYC is increased expression there, and the stats, STAT5 and STAT5B and STAT3 are all on together here in chromosome 17q21, which is often amplified, and then P53 is often deleted, and all of these are genes that are deleted because their chromosomes are missing fragments. And this is where the T cell receptors reside, and you can see that that there's deletion of this in many patients. This is the T cell receptor alpha chain, and gamma and beta are together, so they're deleted. And then there's a group of of P1 that's got a deletion, and then this is the checkpoint inhibitor, the PD-1 and PD-1 ligand, and they're often deleted. So in addition to having single mutations, there are all these deletions and gains in the chromatin that play a role, especially in Sezary patients. So the PD-1 transduces negative signals suppressing T cell function, and there are new drugs, nivolumab and Keytruda, that target this pathway. So far, clinically, there hasn't been reports of any major study there. There's some anecdotal reports of patients who have done well, but there are also anecdotal reports of patients that took off and became tumors and progressed really rapidly. So although we'd like to start using the checkpoint inhibitors in CTCL patients, I think we have to be a little careful there. So we looked at the two deletion of the PD-1 and PD-1 ligand and found that when the 2q deletion was present, then this is poor prognosis for survival. And so the other areas of the microsatellite instability, like in Lynch's syndrome, is present in some Sezary patients, 8%. And there's hypermethylation in 56%. This is work done by Julius Skarsberg a long time ago. There's also the chromosomal instability. You'll see patients who have too many chromosomes. That leads to gain of function for these patients. It's a complex pattern. No two patients are alike. And then I just talked to you about the different deletions and amplifications that occur. So I think that we are making headway in that CTCL and MF patients are surviving longer. And I think that this is because we have earlier diagnosis, because we can use the tools, the flow cytometry, the gene rearrangements, and the PCR of clonality to make a diagnosis earlier. And we can stage the patient using a multimodality approach, and use a multimodality approach to therapy, meaning do skin-directed and systemic therapies for the more advanced patients. We're getting better at recognizing and treating infections so that a patient whose erythroderma gets worse erythroderma, we recognize it might be that they're colonized with staph again. I don't put catheters in my patients. Under duress, I'll put a buried port if they're on photophoresis or something, but they get septic so easily. And then we've replaced cytotoxic chemotherapy with sequential immunologic or targeted therapies. And right now there's 6 drugs approved for CTCL. Tell me if I run over, just throw me off, okay. Okay, so these are the approved CTCL drugs. They're in yellow here. The first one was actually photophoresis, followed by in 1987 and 1997. Sorry, the retinoid. This was bexarotene was approved as the first rexinoid, and then we had Ontac also approved down here somewhere, then came the HDAC inhibitors, and now we're into antibodies like CD30 and folic acid analogs called pralatrexate, which is approved for large cell transformed MF, but you can get it for the MF patients. And so this is just the time scale of this: photophoresis first, Ontac, then bexarotene, histone deacetylase inhibitors, first vorinostat, then depsipeptide, now the targeted antibodies. And what's exciting is the number of investigational agents that are out there to be tested. There are other HDAC inhibitors besides Zolinza and romidepsin, and these panobenostat shows activity in Sezary, and this was approved for peripheral T-cell lymphoma. It could be used for MF. There's some topical immunomodulators, like there's a study of rosiquimod that's going on now, and some data on lenalidomab, low response rate, CPG's a study on that. And then I mentioned the checkpoint inhibitors, but in the MI and RNA inhibitor. And then this is the drug that's about to come out in the next couple of months. Mogalizumab is a anti-CCR4 antibody, and then these are some of the antibodies that have been used. There are two fusion proteins. One is ONTAC, which is now called E-777. It's in a phase 2 trial to get it back on the market. It was taken off the market because of folding difficulties, so we're hoping to get that back to be used. And then there's the CD3 diphtheria toxin. And there's some anecdotal information on protease inhibitors that seem active. So make yourself familiar with the NCCN guidelines, because it divides skin-directed from systemic immunotherapies versus chemotherapies, and it also includes the widely used combination therapies with light and other interferon retinoids. So this is the treatment map. We early on used topicals, nitrogen mustard, light, PUVA, bexarotene gel. As the patient progresses, we get more systemic, and this just kind of shows that. This is a patient, this is just the same as, pretty much the same as the NCCN guidelines. So this is a patient who used targretin gel on his hand MF, and he used it for 10 years, and actually it's more like 12 years now without, if he gets a little spot, he puts a little bit on in it. But the problem with targretin gel is it costs $30,000 a tube, and you can use Sezary instead, but that doesn't get approved for MF, so I appreciate your comments later on what we could do about some of these. This is a patient with equine MF who just gets 2 grays in 4 treatments, and if the lesions never come back. So we use a lot of low dose, like 4 grays divided into 2 fractions for single lesions or recalcitrant lesions that we can't get rid of. If they're tumors, you have to do a little bit more. Okay. So the treatment of 1B to 2A treatment is combining immunomodulatory therapies listed here with skin-directed therapies. The treatment of tumor stage MF, is first line is local immunotherapy. If they have just 1 or 2 therapies, it's maybe important to put them on maintenance. We don't know anything about maintenance in this disease, about what drugs to use. We try to use the least toxic, like bexarotene, but we don't really have good data on that. If people with 2B in tumors relapse, we tried HDAC or denileukin diftatax, or ONTAC was a good one for tumors, and total body skin followed by an allotransplant can be used. This is a patient who actually had follicular trophic MF, had failed all the available therapies that were immunomodulatory, and he got liposomal doxorubicin, a low dose. That's a low dose for that drug, and it was every 2 weeks, and in 8 weeks he's clear. And then we put him on bexarotene maintenance. But the disease always comes back. This shows how helpful PET scans are for following patients with multiple lesions and nodes. And so this shows his 8-week complete response in the skin, or almost complete response in the skin, is mirrored by his PET CT. So as far as tumor teaching points, sometimes tumors are also infected. And if they're black and brown, like they look like ecthyma gangrenosum, that's usually a combination of MRSA or Enterococcus and Pseudomonas. And so they need to be cultured and treated appropriately. Local radiation or topical therapy for single tumors, and for multiple tumors, try not to immunosuppress them. But if you have to, the single therapies like Doxil and Gemzar are very effective. So this is a listing of the most commonly used CTCL drugs. Romidepsin only has an overall response rate of 34%, but its duration of response, 15 months, is excellent. And there are also people who have complete responses to it. Denileukin diftitox has a 30% overall response rate, but a short duration. Although I've had patients with tumor stage MF who have 4 or 5 year complete responses. So it is possible to get that in for Denileukin diftitox. Bexarotene has, this is a falsely low response rate. Really, the response rate for advanced patients with tumors was 45%. It also works long-term for some erythrodemic patients will go into remission with long-term bexarotene. It takes a while for bexarotene to kick in, so you should wait until it has a chance to get into the system. Vorinostat has a very low response rate and a very short duration of response. This is just the ONTAC Denileukin diftitox data, and the registration trial is ongoing to re-register the drug. This is a CD3 diphtheria marker that's in trials right now. And then this is the exciting phase 1 trial of Resimune. I'm sorry, that's the one I just showed you, sorry. So the romidepsin is widely used. It has a lot of activities on different things like angiogenesis, apoptosis, gene regulation, and it's these drugs are exquisitely sensitive in CTCL, so they inhibit all kinds of things that are important for cancer. So they have multiple side effects shown here. And this is the kind of response we got with a patient with follicular trophic. Looks like Alabert's initial patient, but we could get him into a complete response. And that's really important if you're going to do a stem cell. This is an allogeneic stem cell where you replace the patient's immune system with the donor. They go into a chimer situation, and then they can go into complete remission. And we have criteria for this. We want patients to be young and healthy and have insurance. Most important, have caregivers who will be with them and take them to the hospital. And we use total body skin electron beam to clear the skin. You have to get the patient in remission so they don't need the transplant before you do it. And so we've cured some patients. The other group of tumors that are very interesting are the CD30 lymphoproliferative disorders. They're all listed here. MF, transformed MF, often will have expression of CD30, but lower levels than ALCL, but it's not considered part of the spectrum. It's kind of, this patient, you can see, has MF patches and plaques, but also has tumors that might express CD30. And they're different than the patient who just has ALCL cutaneous. And then there's this group of patients who have lymphomatoid papulosis, and their PCP biopsy them and freaks out when the diagnosis comes back large cell lymphoma. So this is what lymphomatoid papulosis looks like. This was a confusing case. It was a CD8 positive, and we were worried that this was something very aggressive, but it turned out just to be LYP, which we can treat with we can suppress it with oral methotrexate or topical clobetasol or oral bexarotene, as well as as well as brentuximab vedotin. And for the residents, it's probably worth memorizing the different types of lymphomatoid papulosis because it may be on your board. And LYP can recapitulate all kinds of other lymphomas like Hodgkin's disease for type A. Type B looks like MF, type C looks like ALCL, type D looks like CD8 lymphomas, and there are more coming on the horizon. And so this just shows the difference with primary anaplastic T-cell lymphoma versus MF that's got CD30 expression. And this is the patient's this shows LYP with CD30 expression. And LYP has a wedge shape histology. So brentuximab vedotin is approved for CD30 positive ALCL systemic, and now for cutaneous ALCL and MF with CD30 expression. It's a molecule that has a target package on it, which is MMAE, which inhibits tubules and causes cell cycle arrest. And whereas this is a very, very effective drug, this carriage also induces neuropathy, which you have to really watch for, and stop the drug if it's occurring. This is a patient with really bad, worst ever MF all over her body, and she has almost complete remission with brentuximab vedotin. And this is a patient who's got mixed lesions. They've got MF, they've got LYP, they have ALCL and some MF, and responded. This is the partial response in the registration trial that has been done. Brentuximab has been combined with methotrexate versus methotrexate and pralatrexate. The arms were equally balanced in the two studies, and this is a recently published thing. In the IT population, there was a 50% overall response at 4 months in MF patients, and in the control, the response rate was only 10%. So that's a big difference. Let's see. This is a waterfall plot of the brentuximab vedotin exposed patients. The overall response in skin was 80%, and in primary cutaneous ALCL, 75% in skin. And you can see, this is the ALCL population. You can see that the brentuximab did a lot better than the control. And these are the individual, each one of these bars is an individual patient. So the response was 42% to methotrexate or bexarotene in MF, and was 80% for the brentuximab vedotin. And patients were able to cross over. And so this is the progression-free for brentuximab vedotin versus methotrexate or bexarotene. These are the side effects. The most important side effect is the peripheral neuropathy that occurs in 67%. You have to watch, you don't want grade 3 or 4 neuropathy. So if it gets to be grade 2, we usually stop the drug. And it seems to be time and disease burden specific. So this is just a summary of everything. Overall response rate of 56 versus 12%. That includes skin, nodes, blood, etc. The overall response without respect to time is 67% versus 20%, with a CR rate of 17% versus 2%. And the progression-free survival is shown 16 months versus 3.5 months. And there was also quality of life included, which was improved in the group. Now this is the last one I'm going to show you. This is the CCR4 receptor, which is expressed in ALCL, MF, and peripheral T-cell NOS. And it's an antibody that fucose is removed from it. It binds to the N-terminus of CCR4, which is a membrane receptor. We have found mutations in the C-terminal in MF, as well as studies from Japan in the HTLV1 population. It has undergone studies in Japan and is approved, and it's currently has finished a phase 3 randomized trial that is called the Maverick trial, and it's studying the efficaciousness of mogalizumab versus vorinostat in previously treated CTCL patients. It's one of the largest studies, randomized studies ever, maybe the first. So this is a study that I did in preparation for the trial of mogalizumab. We did a phase 2. The response rate in MF was 29%. Response rate in Sezary is 47%, for a total of 37%. And this can induce long-term complete responses. This man had a 3-year complete response and died of something else. And if you look at the flow cytometry of the blood, it falls rapidly. These are the 4 positive, 26 negative Sezary cells, and within 1 or 2 doses, they're gone. So I have great hopes that some of the Sezary patients who don't respond to immunotherapy will be helped by this, and it's about to get a full approval, I think. So we have done translational work looking at CCR4 in T-cell patients, Sezary and MF, and you can see that pre and post, there's a difference in CCR4 RNA, and this is looking at also at Tregs going down, and 15 patients had decreased CCR4 Tregs after treatments. So getting rid of Tregs is sometimes good, sometimes bad, but this drug can be used to get rid of Tregs if that's a good thing to do in other cancers besides what we're using it for. These are the mutations that have been reported in the Japanese group and in our group of patients. So this is a difference in the progression-free survival and in the symptoms, or all the things that you could look at were better with mogamulizumab than vorinostat. Okay, and these are the plots, vorinostat versus, you can see this is much better for higher reduction in the MSWAT, which is the skin tool. And there was no difference in the expression of CCR4 in the two responder versus no responder. So that's good news. You don't have to test for the antibody to use it. And the major side effect of mogamulizumab is infusion-related drug, an infusion reaction, which can be just flushing or fever or myalgias. And then about 20% of patients get a drug rash to it, which can be worked through with topical steroids or just time. So this is the summary of the phase 3 trial. The progression-free survival was superior with mogamulizumab. The overall response rate was better, and there are patients who get complete responses to it. So therapies of the future include the microRNA inhibitors. There's a molecule called CD47, which there's an antibody and an inhibitor targeting this. This is the eat me signal that's being looked at now. There's a CUR-D3 antibody that's finished its first phase 1 trial and will go into phase 2 trials. There's the CD3 diphtheria toxin and the E77 that replaces ONTAC. And then there are dual kinase inhibitors that inhibit the AKT pathway. And finally, the diffuse large B-cell population of people who used to die from diffuse large B-cell, 50% of them are getting complete responses with the CAR-T therapy. And so we need to have CAR-T therapy for MF and Sezary, and I'm going to put my first relapsed Sezary patient on it in a couple of weeks, and the target there is CD5. And then finally there's a JAK-SYNC inhibitor that is in clinical trials for other lymphomas, but they're committed to doing a CTCL trial. And then there's a really interesting pill that you take once a week called ONC201 that inhibits the pathway, all three pathways that we need to inhibit for CTCL to be successfully gotten rid of. So this is just my conclusions, and you can read them. And thanks for listening, and I'll be glad to answer questions. Yes, I'm writing them down.
I just have a quick one, clinically. Yeah. So if you get a patient you're worried about early patch stage MF, and they've either been referred to you or someone else is treating with topical steroids, how long do you think you have to wait to biopsy and get a light?
I think at least a month.
At least a month.
I think that it doesn't matter whether an early MF patient has MF or doesn't have MF, because the treatment's the same. But it does help not to waste the patient's money by doing biopsies that are going to be negative just because they've been using steroids. Waste time or waste money. Yes, sir.
Can you have a steroid-free area?
Yes, that's what I do.
Okay. And you mentioned disseminated, like the early lesion, and then you used the word disseminated. But I wanted to understand whether advanced CTCL is disseminated from a primary, or if essentially it's universal, multifocal primary disease.
Well, I don't know. I think it's really interesting, though. That, I mean, there are patients who they have one patch, and they have one patch for 30 years.
Right.
You know, it's usually poikilodermatous.
Yes.
But then you have that one little area that starts it out visually. It's the only one they have. And then within the next year, they will blow up with it everywhere else or other places. And it's like PR in that sense, that there may be an initial lesion that starts it off. Now, whether they have a mutation that makes them do that, or their immune system gets down and it just disseminates, I don't know.
I would always thought of it like Kaposi sarcoma, where you may have an initial lesion, but the subsequent lesions are not metastases,
Right.
they're individual primaries.
Well, I think we could answer that question with sequencing different lesions. You know, just taking a sample and then sequencing. The problem with sequencing is you've got to get a purified cancer population, because if you just throw it in there as a gamish, you'll get a polyclonal sequencing pattern. So it's hard.
And the problem with the early diagnosis is that you can have, some of these patches, they have relatively few abnormal cells, so you just don't have enough of a population to know. We used to do these thin film sections, like ultra thin film biopsies, and you could then look specifically at the morphology of the nuclei. You can really see cerebriform cells. That what you would see in your Sezary patients if you did those ultra thin sections. But on a regular section, they're just sort of dark lymphocytes, and you can't make out any morphology. They all look the same. So that's why you're not getting a diagnosis. But if they did thin sections, you would see the cells.
What about using EM microscopes?
Oh yeah, I mean, if no one does that anymore, but yeah, if you submit for EM, you get very angry.
Is there any room for the confocal? Do you all have confocal microscopes? We don't, but that might be a way of diagnosing. We don't have them either.
It sounds like things are going to move more in that direction. The AD has been developing statements around use of confocal microscopy. So the people who are really into it in this country feel pretty strongly that it's going to take a bigger hold over time.
I would think you could tell a Sezary cell from a normal lymphocyte if you had a confocal, or at least where they are. I don't know.
The confocal, it's laser, but you're talking about doing scanning.
Yeah. Yeah.
She's talking using
Actually,
a confocal
sections,
microscope instead of visible light.
Right.
You're using laser light, and you would probably get more detail if they had. What we were doing was we got so frustrated with these diagnoses, and I'm a dermatologist. We would be doing cutaneous flow, taking the actual skin.
Yeah, you can do that. Yeah.
And
if you have enough
dissecting
cells.
out the lymphocytes. You could get the lymphocytes out, then you can look at relatively small populations of cells and discover abnormal phenotypes.
Yeah, if you could dissect the tumor cells and sequence them, that would also
Yeah, you
give
can
you
sequence them, and you can do the sequencing, or you can just see that, wow, here's a population of cells, although small, that have 4 positive, 7 negative phenotype, which is an abnormal phenotype, and that would make the diagnosis. But it is frustrating, the early disease.
Well, thank you very much.
so much.
Thank you.